Welcome to The Scope with Dr. K. I'm Dr. Kosinski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. We are moving back to the health plan side today. Our guest is Krishna Ramachandran, Senior Vice President for Health Transformation and Provider Adoption at Blue Shield of California, which is a nonprofit health plan with $24 billion in annual revenue, serving almost 5 million members. In this role, Krishna is responsible for leading partnerships and innovations to improve healthcare quality and affordability for Blue Shield's members, bringing tools and support that benefit providers and promote health equity and healthier communities throughout California. Previously, he served as Divisional Senior Vice President of Healthcare Delivery at Blue Cross Blue Shield of Illinois, where he led contracting, collaborating with providers in Illinois to improve health outcomes and reduce costs of care. I know him from those days. We're going to talk about his Blue Cross Illinois experience on the show today. Krishna is passionate about collaboration, innovation, and use of technology, analytics, and incentives to improve patient access, their outcomes, and affordability. Earlier in his career, he served as Chief Information and Transformation Officer at Dooley Health, the largest provider-owned multi-specialty group in Chicagoland. Finally, he served as Director of Technical Services at Epic. So his experience goes across the provider and health plan space, even the technology space. Perfect for our show. He holds a Master's of Science degree in Electrical and Computer Engineering from University of Illinois Chicago and an Executive MBA from Northwestern University's Kellogg School of Management, my alma mater as well. I had the opportunity to listen to Krishna's presentation at PTAC last month, where he presented on issues related to selecting and designing quality measures for population-based total cost of care models. We're going to tap that as well today. Welcome to the show, Krishna.
Thanks for having me, Larry.
Well, it's our honor to have you on. So let's jump in and begin. I always like to begin the podcast by allowing the guests to tell us a little about themselves in their own words. As I said in my intro, I'm impressed with the breadth of your experience. You're an engineer by training and started your career in the EHR space at Epic. Then you went to the provider side with the largest multi-specialty group in Chicago, and then landed on the payer side where you're actually on the cutting edge of value-based care there. That's quite a journey. So how do you think your core engineering training helps you in what you do today?
Thanks, Larry. At the core, I'm a people-oriented problem solver who is driven by the desire to make a difference in healthcare. So the engineering principles were really key for me to help decompose a complicated problem into parts and then be able to find creative solutions. So as much as I've left my code engineering work behind a few decades back, I still use what I've learned in engineering school very regularly in my day-to-day.
Yeah, a people-oriented problem solver. That's pretty cool. So you spent a lot of time at Dooley on the provider side as well. How does that help you in what you're doing?
I loved my time on the provider side. It was so cool to implement things in partnership with physician leaders, test it, and really be able to see the impact of the changes, in terms of how it manifested from a patient experience perspective. So it was really cool to be able to have an idea, work with physician leaders, implement it in practice, and then see the results. And so that, the life cycle was so quick and so neat. I had a chance to, of course, work with physicians from all different specialties and hear their perspectives and partner with them across the board. And so that was really unique, whether it's value-based care, whether it's implementing, optimizing electronic health record software, or doing innovations like online scheduling, video visits, virtual visits. And so it was just cool to be able to have that experience.
Well, I love the fact that you were talking about how nimble it was to be able to, impact change from the provider side. you're on another side right now. So you're on the health plan side, and I was impressed with what you were able to do at Blue Cross Illinois from a value-based care point of view. Um, one of the one of your initiatives that really struck me was what you did with moving endoscopy cases, not only out of the hospital setting, but also beyond the ASC into the office setting. What Blue Cross Illinois set up was really cutting edge, and you maintained quality and patient satisfaction, but markedly lowered the cost of care. And today, I don't know how much you keep back in touch with your folks back at Blue Cross Illinois, but today new endoscopy suites in Illinois are being built as office centers, even by hospital systems. And this is really impressive. Can you tell us about that initiative and any others you developed at Blue Cross Illinois?
Yeah, it's a power of aligning incentives, right? Like in action here. So it is really neat to see when the right incentives are there, the healthcare system is capable of moving and moving to the place of high quality and more affordable sort of setting as well. So really a good example of where, when we can align all the incentives with the stakeholders, healthcare is able to, show what can be done. And that's one of the things I've really appreciated being on the payer side, right? The opportunity to use the healthcare spend. So Blue Cross Blue Shield of Illinois was $36 billion in healthcare spend every year. And so being able to use that to drive change and to align incentives with stakeholders is very unique. And really, you're able to do change at scale, which is what I've really enjoyed about the payer side. It moves slower, certainly, but when it moves, the wake is quite dramatic, and the opportunities are quite significant there. So really excited to see the progress you were sharing as well, Larry, on the endoscopy centers, the movement from hospital to outpatient into office settings. So really, really proud of the progress there as well. I think about value-based care as almost as a portfolio approach. We need to create a wide set of models that cover, all aspects of the healthcare spend. And, they're much like a financial portfolio. They all have different purposes and have different sort of, sharpness and how they engage the healthcare system. And naturally the returns and benefits, the improvements in quality or affordability as well that come with it. But we've created a number of models, both in Blue Cross Blue Shield of Illinois as well as in Blue Shield of California, where we want to cover the spectrum of healthcare spending that happens, in the state. Certainly, starting with the total cost of care models, like the accountable care organization models. Given California's footprint, the capitation HMO has been a long-standing part of the value-based care portfolio here in the state. And then we've really continued to engage specialists and specialty associations to move into the specialty domain, particularly with a focus on episodes of care models as well. So we are excited to continue to, build a portfolio, but also engage various stakeholders that in the healthcare landscape as well, using those portfolio.
So, I know the laws are different between Illinois and California. Are there specific hurdles that you have to get over in California that you didn't have to worry about in Illinois?
They're pretty similar. I think the where each state is different in the journey. Like, California has been sort of deeply, capitation has been a part of the model for many decades. In Illinois, it was really primary, Blue Cross Blue Shield of Illinois was the leader in the capitation world, and it wasn't sort of widely embraced by other payers in the market there. So there's many similarities I find, and many learnings in the approach that both plans have taken. California also has, I think the states leaned in as well. One from the Office of Healthcare Affordability perspective, like they really want to make continued affordability and solutions a priority as well. California has also leaned in from a multi-payer perspective. They've really brought together multiple stakeholders, together to sort of solve particularly value-based care and try to further value-based care together across multiple payers. And so certainly some uniqueness there, and more lean in from the employers, the regulators, other nonprofit organizations as well. So, which has been really, really, really unique to get to know and be a part of it.
You mentioned ACOs, and one of the things we've talked about at PTAC has been how CMS should interact with ACOs. From a health plan point of view, you can't get very prescriptive with how the ACO functions, but can you innovate in an ACO without mandating? I mean, how do you interact with the ACO to help promote more value?
ACOs are key parts of the value-based care portfolio, particularly, large population-based models. They certainly have coverage from a membership and attribution perspective. And to your point, they give the systems most flexibility, given that you're really caring for a population. And so I think keeping the sort of goals front and center, like how do you measure quality? How do you improve quality? What are the measures that matter? And then, of course, making sure that we are using value-based care as a vehicle to bend the cost curve is key as well. And I do think between those two sort of, North Star aspects of it, there's a lot of room to flex. And health systems and provider groups that have invested in the resources, the assets, the analytics to help innovate and manage a population do really well in them. And so we want to create a space and place for those health systems to innovate. What I also learned at Blue Cross Blue Shield of Illinois was giving providers and health systems the tools, those that have not made the investments. How can payers actually make some of those investments in data exchange, whether it's in surfacing up meaningful, actionable insights and analytics in order to help providers focus on the patients and places that matter to improve quality and reduce costs. I think those have been helpful. So I think there's a role to create space, but also meaningfully partner by actually providing resources from a payer perspective to providers to help them actually innovate and achieve the goals of a population-based total cost of care model.
Boy, you're preaching to the choir here, Krishna. The providers do need financial operational assistance to convert from their fee-for-service models into value-based care. It's not just something where we can expect them to succeed without some assistance. I'm going to break right here for a second. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Krishna Ramachandran, Senior Vice President for Health Transformation and Provider Adoption at Blue Shield of California. Let's shift our focus here to BSC. At PTAC, you introduced BSC as, quote unquote, a rebel with a cause, a nonprofit tax-paying health plan on a mission to create a healthcare system that is worthy of our family and friends and sustainably affordable for everyone. That's a great statement. I had to write it down and use it for this podcast. So, Krishna, what does that mean to you? Tell us how that translates into the work you're doing.
The healthcare, as you know, Larry, is very unaffordable, and the healthcare system at large is deeply unpopular in this country, and only becoming more so. The spending has been growing, and it's just a lot of stakeholders, from employers and purchasers and regulators, are all saying this is just unacceptable. Blue Shield of California also thinks so, and it is really leading the way to overcome the problems in the industry. Their mission to create a healthcare system that is worthy of our family and friends and sustainably affordable for everyone was definitely what drew me to them. And the opportunity to partner, innovate, and make a difference in this healthcare system is what I'm most excited about.
So how are you accomplishing this? Can you give us some examples of how BSC is doing this?
Absolutely. We think about our health transformation in several pillars. One is just bringing healthcare into the digital age. We are investing in tools and partnerships in order to move data seamlessly between providers and payers, use the data in order to surface up insights. We've invested in platforms to help us with more, digital care management. We've leaned in to create more access from a virtual perspective with our Virtual Blue product. I've invested in platforms to do digital therapeutics and tools for members for weight management, diabetes, mental health, and other chronic conditions as well as part of our Wellvolution platform. So that's one area we are leaning in and want to bring healthcare into the digital age. Two, a topic close to your heart, Larry, tying payments to value. We want to make sure that all of our payments are tied to value in the future. More than half of our primary care physicians participate in value-based care arrangements with us, and we want to grow that certainly for primary care physicians, but also for health systems and specialty physicians as well there. So we definitely want to keep that one going there as well. Our primary care models has had really good success. In fact, healthcare costs dropped about 10% amongst participating providers. And so we are seeing improvements in quality and seeing the results from a cost of care perspective as well. So we are excited to scale that more as well to our own providers, and certainly leading efforts with other payers as well in the state of California to further our multi-payer primary care collaborative and work as well. Three is accessibility and affordability of prescription drugs. Clearly, a huge part of healthcare spend is in prescription drugs. We announced our Pharmacy Care Reimagine program, a new approach where we are really trying to go directly to pharmaceutical manufacturers to improve the member experience and reduce extra costs from the middle stakeholders in the mix as well. And so we really want to revolutionize how we do pharmacy care in this country. The other pillar for us is just health equity, making sure that our members and residents of California have access to high quality, equitable care. We want to raise awareness of colorectal cancer with screenings and health education. We partnered with a Latino focused provider called Zocalo. We've done community education sessions there. We are focusing on maternal child health equity, particularly with a lens on providing virtual and physical doula services, a partnership we've had with Mommy, as well as other community-based organizations. So we are definitely continue to focus on health equity and furthering the work we're doing there as well. So yeah, those are some ways and examples by which we are bringing our Health Reimagined strategy to life.
Well, thanks for the granularity. That helps me move to my next focus. I want to move towards the specialty space more. I published a paper a couple of years ago on nesting, on nesting specialty-based, value-based care models inside these large population-based total cost of care models, because I really think we have to structure it that way. At PTAC a few weeks ago, you said that your value strategy is focused on alternative payment models that, of course, would deliver higher quality care, lower costs, and an exceptional member experience. So how are we going to have the specialists involved in this? I firmly believe your primary care strategy is a sound one. We see this nationally in some of the large, big national primary care groups taking on risk and moving things from the bottom up. We also talked about the ACO, the population-based models moving down from the top, but in the middle there, we've got specialists, and they are still paid on a fee-for-service basis in almost all cases. How are we going to integrate the specialists further into these models?
Yeah, great comments, Larry. And as you know, fee-for-service is a broken system. We want to create models that can accommodate all providers, and certainly models that can deliver higher quality care, lower costs, and while creating an exceptional member and provider experience. The goal certainly is to improve outcomes and improve well-being for all Californians and, of course, all Americans for that matter. Specialists have, I think, largely been left out of value-based care in a very targeted sort of manner, right? Most of the population-based models that you spoke about have been very primary care focused, and not to say, I mean, the primary care, of course, is integral and thoughtful, holistic, coordinated primary care is very important for the health and well-being of everybody. I say engaging specialists is very key, both in the context of a total cost of care model, but as you called it, also how do you nest it? How do you create sort of granular engagement there? From our perspective, we've used episodes of care as our vehicle to engage specialists and continue to scale how we can scale those models to involve specialists in the process. We are engaging with specialty societies, particularly to help us what we should measure, like what are the measures that matter? What are the measures that actually help improve outcomes and reduce costs? And just getting their advice on how do we dock into the specialty side of the equation, and how can they help us with overall cost of care models as well as episodes of care models as well. So we are eager the work we're going to be doing with you in GI will be key for us as well, and to help us sort of navigate that space. And I like the work you're doing with the nesting as well, because as these models scale, both episodes of care as well as primary care and total cost of care, we clearly have to figure out how do these models, how does this portfolio interplay, much like a portfolio of models that are going to be elements that overlap and intersect. And so we need to sort of figure out how we can optimally do nesting, so that we can keep the right stakeholders engaged, but also not lose value from very specific targeted models as well, which I think is key, particularly engaging specialists. And I think our approach so far has been, engaging with the specialty societies. We've engaged with American College of Cardiology, the California Orthopedic Association, as well as broader medical associations like the California Medical Association, the National Quality Foundations, really to get feedback on measures that matter, and then tools and resources and sort of model structures that actually will help with engagement of specialists, and also help move the needle on high quality, cost effective care as well. So we're excited certainly for the journey with you all and Stone RMD as well, and the process, and certainly with other specialty societies as well.
Final point I have to ask you about. Gastroenterologists probably derive 70% of their revenue from colonoscopy, from doing an elective procedure, a well-compensated elective procedure on a healthy population. And then when we go in with value-based care, the incentives for the value-based care just can't compete with the revenue they're making from doing those colonoscopies. We've got to get the payment model adjusted so that if we want providers to be participating in value, we need to compensate them more for the value and maybe less for the non-value. But I don't think we're going to get there otherwise.
Yeah, I agree with you. I think it's what I find particularly is it's the whole process of how is value created, and then how do you sort of ascribe value and allocate value is a complicated topic, right? Like how
Yeah.
what I liked about the total cost of care models is that there is sort of an alignment on like, hey, if you're able to create total cost of care, sort of value, then everybody sort of wins in the process. We can sort of take care of a population as a whole. The challenge is it's so broad and so big. It's hard to sort of like, creating actionable sub goals is a challenge I find in total cost of care models. And so, I think the right answer is how do we have the best of both worlds? And how do we still create alignment for population health, like sort of a revenue model that is derived on population health, while still making sure the components of population are achieving population health, the various specialists involved, including GIs, the sort of compensation model reflects that as well. And so certainly, easier said than done, but I think that's our opportunity. How do we get the best of both worlds? The specificity of an episode of care type model, while the population-based, revenue and dynamics of a total cost of care model. So, more work. And those are, I think, certainly opportunities for us to collaborate together, particularly with the specialty societies as well, because it's not an easy answer at all, and it's going to require just a holistic rethinking of what we've done so far as well.
I agree. A holistic rethinking of what we've done so far. It's going to be a work in progress for a long time. Well, Krishna, thank you very much for being on the show. I'm going to continue to follow your career because I'm certain it's going to bring some interesting things to Blue Shield of California, and I look forward to working with you further through Sonar there. Thank you for taking the time today with us.
Thank you so much for having me, Larry. It's a pleasure talking to you.
Well, in addition to thanking Krishna, I would like to thank the audience for tuning in. You can access our podcasts on most all of the podcast platforms like Apple Podcasts, Google, Spotify, and others. Learn more about the show on the program's page on healthcarenowradio.com. Lend your voice to the conversation on X at HCNow Radio. Be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.